Evening, my dear friends and colleagues. Today, our topic is about cryoglobulinemic glomerulonephritis. Cryoglobulinemia is an important topic, and we are seeing a lot of cases in our practice regarding cryoglobulinemia. So we will talk about it today in details. This is our agenda: definition, classification, clinical manifestations, how to evaluate, and treatment. Cryoglobulins, from its names, it is divided into two parts, globulins and cryo. Globulins, so they are immunoglobulins. They are immunoglobulins. And the second part is cryo, immunoglobulins that precipitate at cold temperature. So they are immunoglobulins that precipitate at cold temperature and dissolve when rewarmed. This is very important regarding diagnosis of cryoglobulins. So there are two conditions regarding immunoglobulins, that they precipitate at cold temperature and they dissolve when rewarmed. Cryoglobulins can present in infections, as we will see, autoimmune diseases, monoclonal gammopathies. But these are the conditions that can cause cryoglobulins. Usually they present in the renal biopsy with membranoproliferative pattern, membranoproliferative glomerulonephritis in renal biopsy. And what is characteristic for cryoglobulins is the presence of intraluminal deposits. Intraluminal deposits, immune microthrombi. They are the cryoglobulins, suggestive cryoglobulins. This is very important. When I should suspect cryoglobulins, if the renal biopsy shows MPGN, membranoproliferative glomerulonephritis, with intraluminal deposits suggestive of microthrombi from cryoglobulins. What about the classification? Cryoglobulins are classified into three types: type 1, type 2, and type 3. Type 1, cryoglobulinemia, characterized by monoclonal immunoglobulins. This is very important. Monoclonal immunoglobulins. Usually from an underlying hematological malignancy. From underlying hematological malignancy. يبقى type 1 cryo. Type 1 cryo is monoclonal immunoglobulin. Usually with hematological malignancies like Waldenstrom macroglobulinemia or multiple myeloma. In the absence of criteria for hematological malignancy, if the underlying disease doesn't fulfill the criteria to be diagnosed as Waldenstrom or myeloma, so a diagnosis of monoclonal gammopathy of renal significance should be established. Monoclonal gammopathy of renal significance if the criteria are not fulfilled for multiple myeloma or Waldenstrom. The cryoglobulins are usually IgM, mostly IgM or IgG, but also IgA and monoclonal free light chains can be occur, but the most common is IgM. So in type 1 cryoglobulinemia, they are monoclonal immunoglobulins, usually with hematological malignancies. What about type 2? Type 2 and type 3 are called mixed cryoglobulinemia. Type 2 is characterized by monoclonal IgM, against polyclonal IgG. Again, a mixture of, so it's called mixed cryoglobulinemia. Monoclonal IgM against polyclonal IgG. In type 1, only monoclonal immunoglobulins. But in type 2, there is a mixture of monoclonal IgM against a polyclonal IgG. And this monoclonal IgM is characterized as having a rheumatoid factor activity. Rheumatoid factor activity. If we asked for a rheumatoid factor test, it will become positive rheumatoid factor activity. This is very important for diagnosis and in clinical practice. In type 1, the most common causes are hematological malignancies, but in type 2 and type 3, the most common cause is infections, chronic infections, especially hepatitis C virus. So the most common cause of cryoglobulinemia is hepatitis C virus infection. This is very important. Also, hepatitis B and HIV can cause cryoglobulinemia, but the most important and the most common is hepatitis C. Also, autoimmune cryoglobulins can occur with autoimmune diseases, and the most important one is Sjogren. Sjogren syndrome is usually associated with type 2 cryoglobulins. What about type 3? Type 3 is also mixed, but in type 3, both IgG and IgM are polyclonal. Both are polyclonal. So in type 1 is monoclonal, type 2 monoclonal IgM against polyclonal IgG, but in type 3 IgM and IgG both are polyclonal. Causes include HCV again, also chronic inflammatory and autoimmune diseases like lupus and Sjogren, and also lymphoproliferative malignancies. Also type 3 mixed cryoglobulinemia can occur in lymphoproliferative disease. As you can observe that there is significant overlap between the causes of type 2 and type 3, including hepatitis C and autoimmune diseases and lymphoproliferative malignancies. All of these can cause either type 2 and type 3. This is a table showing what we said. In type 1, usually monoclonal. Most class of immunoglobulins, the most common is IgM, followed by IgG, followed by IgE, and then free light chains. Type 1 is usually, as we said, is usually associated with hematological malignancies, myeloma, CLL, and Waldenstrom. Type 2 and type 3 both are mixed, but in type 2, it is formed of monoclonal IgM against polyclonal IgG. The most common cause is hepatitis C, also Sjogren and lymphomas, but the most important is hepatitis C. Type 3, both IgM and IgG are polyclonal. Usually the same causes for type 2 can cause type 3 cryoglobulinemia. What about the clinical manifestations of cryoglobulinemia? Cryoglobulinemia is usually caused by deposition of antigen-antibody complexes. So it is mainly the clinical manifestations are due to antigen-antibody complexes which deposit in capillaries and small arterioles. As we said, that most cases are usually associated with hepatitis C virus. In the majority of hepatitis C virus causing cryoglobulinemia, the immune complexes consist of HCV virus and the antibodies. And usually, as we said, it is mainly type 2 mixed, or type 2 is formed of monoclonal IgM against polyclonal IgG, and this monoclonal IgM is associated with rheumatoid factor positivity. Clinical manifestations of mixed cryoglobulinemia include weakness and, most importantly, palpable non-pruritic purpura. This is very, very important. Non-pruritic purpura. Also arthralgia, peripheral neuropathy, and renal involvement. So criteria or the clinical manifestations for cryoglobulins include, especially we are talking about type 2 and type 3, weakness, purpura, arthralgia, peripheral neuropathy, and renal involvement. Again, purpura is palpable and non-pruritic. Purpura is also painless, non-pruritic, mainly in the lower extremities and buttocks. Other manifestations for cryoglobulinemia include digital necrosis, congestive heart failure, pulmonary infiltrate, and mesenteric ischemia, and most of these manifestations are due to the immune complex deposition. What about type 1? Clinical manifestations of type 1 are usually, most of the cases are usually asymptomatic. Renal disease usually occur in 20 to 60% of cases, and the clinical presentation varies from microscopic hematuria and low-grade proteinuria to a full-blown nephrotic and nephritic syndrome. Hypertension is common and can be severe. And renal disease or the renal affection in cases with cryoglobulinemia is the major determinant of long-term prognosis and mortality. This is the purpura, palpable, non-pruritic, painless purpura, usually in the lower extremities and buttocks. Very characteristic. Very characteristic. This is picture showing necrosis in the fingertips due to a thrombi with antigen antibody complex deposition in small arteries and arterioles. Necrosis. What about the evaluation? What are the investigations that are suggestive of cryoglobulins? The most important is low level of C4 and normal C3. Again, the most important is consumed C4 and normal C3 and a positive rheumatoid factor. So whenever you suspect cryoglobulinemia in a patient coming to you, hepatitis C patient coming to you with purpura or proteinuria and hematuria and arthralgia, and you suspect cryoglobulinemia, I should ask for C4 and C3 and rheumatoid factor. If the investigation result showed consumed C4, normal or mild decrease in C3 and positive rheumatoid factor, this is highly suggestive of cryoglobulinemia. How to collect a blood sample to detect cryoglobulins? This is very important, very crucial, because it carries many mistakes that can result in a negative test. The patient can have cryoglobulins and the result come to us with negative test due to poor collection of samples. Blood should be withdrawn in collection tubes that have been pre-warmed to 37 degrees. So the blood sample should be transported at a degree of 37 degrees without anticoagulation. Again, a cryoglobulins or the blood sample should be transported to the lab at a temperature of 37 without anticoagulation, because anticoagulation can cause false positive result. However, in up to 40% of type 2 and in some cases of type 3, cryoglobulins may not be detected. If we took all measures, in a significant proportion of around 40% of cases, cryoglobulins may not be detected, but the patient still have cryoglobulins. So, what to get in a patient, usually hepatitis C virus patient, or a patient with clinical picture highly suggestive of cryoglobulinemia in the form of palpable non-pruritic purpura, erythroalgia, hypertension with consumed C4 and positive rheumatoid factor, treat the patient as having cryoglobulinemia, even if the cryoglobulins are negative, because in up to 40% of cases, cryoglobulins may not be detected. Also, in some cases, renal disease present in the absence of detectable cryoglobulins or other manifestations of mixed cryoglobulinemia, such as purpura and arthritis. And here we depend mainly on the renal biopsy. There is a poor correlation between clinical manifestations and the presence of cryoglobulins in the lab. So when I suspect, I should ask for C4, C3, and rheumatoid factor. On renal biopsy, what is the pattern? The pattern is mainly MPGN, membranoproliferative glomerulonephritis. In most of the cases, in around more than 80% of the cases, the main lesion is MPGN. But what are the light microscopy findings? In light microscopy, what are the findings that point towards a cryoglobulinemic? These findings are very important. Number one, a greater number of macrophages, also the presence of intraluminal thrombi. These are the two landmarks in renal biopsy to suggest that there is an underlying cryoglobulinemia. So, MPGN pattern with intraluminal thrombi and a greater number of macrophages, all of these are suggestive of cryoglobulinemia. What about immune fluorescence? There is diffuse IgM deposition. And in electron microscopy, there is subendothelial deposits. With a characteristic fingerprint pattern of cryoprecipitates. Again, if you are asked about the renal biopsy in cryoglobulins, in light microscopy it is MPGN with intraluminal thrombi and increased number of macrophages. Immune fluorescence, there is diffuse IgM deposition, and in electron microscopy there is subendothelial deposits and a characteristic fingerprint pattern of cryoprecipitate. This is renal biopsy findings. What about type 1 cryoglobulins, which are mainly due to monoclonal immunoglobulins? In type 1. Also, there will be intraluminal positive deposits on light microscopy. But the most important in immune fluorescence that this immunoglobulin is mainly monoclonal on immune fluorescence. This is very characteristic. Also in electron microscopy, we might find microtubules, fibrillary, and fingerprint. But the most important and the differentiating point is in immune fluorescence that we found that the immunoglobulin is monoclonal, not polyclonal. This is the biopsy images for a case of cryoglobulinemia due to Sjogren syndrome. Here in image E, this is periodic acid chief stain light microscopy, and here light microscopy with Mason trichrome. Here we found an MBGN pattern, thickening of the basement membrane and increase in number of cells. MBGN pattern. What is the characteristic? Is the presence of intraluminal thrombi. Here, intraluminal thrombi representing the cryoglobulins. Again, look at the black arrows. Intraluminal thrombi. These are the cryoglobulins. Here also. These are the cryoglobulins. Here again. So we found in light microscopy MBGN pattern with intraluminal thrombi. What about immune fluorescence? There is granular staining for here IgG, also granular staining for IgM, C3 and kappa, and lambda light chains. What about the electron microscopy? In electron microscopy, here we see intraluminal deposits and subendothelial deposits. These are the intraluminal deposits, and here is the double contouring with MBGN pattern and subendothelial deposits. What about treatment? Treatment, there is KDIGO published in 2018 guidelines for the management and diagnosis of hepatitis C and CKD. So we depend mainly on these guidelines about the management of hepatitis C virus diagnosis and management in patients with renal problems. They recommend, this is the summary of all recommendations, and then we will talk about each one of them in details. They recommend that kidney biopsy should be performed in HCV infected patient with any evidence of glomerular disease. So kidney biopsy is very important to detect the exact pathology and to determine the level of affection, if there is more active inflammation or there is interstitial severe fibrosis. There is recommendations that patients with HCV associated glomerular disease should be treated for hepatitis C. So all of them should be treated with treatment for the HCV, which is the main cause. Patient with HCV related glomerular disease with stable kidney function and or non-nephrotic proteinuria should be initially treated with direct antiviral drugs. So if the kidney affection is not that severe or with a stable kidney function or proteinuria that is non-nephrotic, the main treatment should be against the virus with direct antiviral agents. But in patients with cryoglobulinemic flare, cryo with cryoglobulins, patient with HCV and the cryoglobulins, or with nephrotic syndrome, or with RBGN, should be treated in addition to the direct antiviral, should be treated with immunosuppressive agents with or without plasma exchange. Again, in patients with HCV that present with cryoglobulinemic or nephrotic or RBGN, the treatment should include direct antiviral, immunosuppressives with or without plasma exchange. In patient with glomerular disease related to hepatitis C virus who did not respond to antiviral therapy, as we said from the start, if the condition is stable, we should treat early for direct antiviral. But if no response to direct antiviral, especially with cryoglobulinemia, we should treat by immunosuppressive drugs. One of the most important recommendations that the first line immunosuppressive drug for cryoglobulinemia or HCV related glomerulonephritis is rituximab. The first line drug nowadays, after recent randomized control trials, is rituximab, is the first line immunosuppressive treatment. This is the summary of recommendations. Let's talk with some detail. Patient with HCV associated glomerular disease, we should treat, as we said, we should treat the HCV. Because the antiviral therapy has been used to achieve clearance, this is the cause. It will cause clearance of the HCV and ameliorate the renal injury. I treat the cause. I remove the antigenemia. So I should treat the hepatitis C virus. In all patients with proteinuria reduction, HCV RNA clearance was observed at the end of antiviral therapy. So in patients receiving antiviral therapy with clearance of the HCV RNA, there is proteinuria reduction. This is the base for that recommendation that we should treat the cause. We should remove the antigens. We should treat the virus. To support also, regardless of the regimen used for treat HCV, either interferon-based or direct antiviral agents, antiviral treatment has some limitations that we should take care. First, that the impact of this antiviral therapy on long-term outcomes for the kidney remains uncertain. We don't have any data for long-term follow-up of patients treated for HCV with glomerular affection. With most of the studies have a short period of follow-up. So the impact of this antiviral therapy on the kidney on long-term basis is uncertain. Secondly, there is reported high rates of marked improvement on various cryoglobulinemia related manifestations after sustained virological response with direct antiviral, but there is higher relapse rate have been observed, and we have seen that in clinical practice. We have seen many patients treated for HCV, and after 1 to 2 years there is a relapse and the patient come to us presented by cryoglobulinemia after 1 to 2 years with treatment of direct antiviral drugs. Let's talk about the immunosuppressive agents that can be used. Immunosuppressive agents should be used with serious life-threatening complications of cryoglobulins. The most commonly used immunosuppressives include cyclophosphamide, steroids, and plasmapheresis have been used also. Cyclophosphamide have been used to improve the kidney by reducing stimulation of B lymphocytes and the cryoglobulin synthesis. steroid pulses have been given to treat glomerular inflammation, and plasma exchange have been used to remove circulating cryoglobulins from the plasma, and this will lead to reduction of the immune complexes deposited in the kidney. So the most common immunosuppressive drugs are cyclophosphamide and steroids, and in some cases we use plasma exchange according to the severity of the condition. In patients with nephrotic range proteinuria and or RBGN presentation and acute flare of cryoglobulins, control of the disease by immunosuppressive medications plus with or without plasma exchange should be considered. So in these severe conditions, nephrotic range proteinuria or RBGN or acute flare of cryoglobulins, we should treat by immunosuppressives with or without plasma exchange. Plasma exchange usually are used in a dose of 3 liters of plasma 3 times weekly for 2 to 3 weeks. This is the usual plasma exchange prescription. Plasma exchange thrice weekly for 2 to 3 weeks. And this immunosuppressive and plasma exchange should be used before the initiation of direct antiviral drugs. Also, another regimen according to the recent guidelines is that the first line immunosuppressive drug is rituximab. Rituximab is usually used at a dose of 375 mg per square meter weekly for 4 weeks. So we give rituximab weekly for 4 doses for 4 weeks. Rituximab can be used as a monotherapy alone or can be used with corticosteroids. So rituximab, the initial regimen is rituximab plus or minus steroids, with or without steroids. The second regimen is, if rituximab is not available, is cyclophosphamide 2 mg per kg per day for 2 to 4 months plus steroids, usually with methylprednisolone pulse 0.5 to 1 gram per day for 3 days. So we have 2 regimens, rituximab plus or minus with or without steroid, rituximab alone or with steroids, or the second regimen is cyclophosphamide and steroids. The decision is for the clinician to use immunosuppressive alone or combine immunosuppressive plus direct antiviral therapy. Direct antiviral should be used, but the controversy is about the timing of starting direct antiviral drugs. They can be used either from the start or as most of us usually start with severe conditions, usually start with the immunosuppressive drugs with or without plasma exchange first and control the disease, decrease the inflammation, and then we can start direct antiviral drugs usually 1 to 2 months later. What about rituximab? As we said, rituximab is now the first line immunosuppressive drug to treat HCV related glomerular disease and cryoglobulinemia. It has shown encouraging results. Rituximab is a human mouse chimeric monoclonal antibody against CD20, selectively target B cells. Rituximab interferes with the synthesis of cryoglobulins, monoclonal IgM, and the renal deposition of immune complexes. This is the mechanism of rituximab. Decrease synthesis of cryoglobulins. Rituximab, there are 2 RCTs that demonstrated the superiority of rituximab monotherapy as compared to conventional immunosuppressive therapies, but there are two side effects or two concerns with the use of rituximab. The first one is frequent relapses, which is a common concern with the use of rituximab anytime. So repeated rituximab infusions may be used, and these repeated infusions usually will lead to put the patient at a higher risk for infections. So the two major concerns with the use of rituximab is the relapses and infections. This can lead to a reactivation of HCV or more frequently hepatitis B virus. This is a major concern with rituximab use. Now let's summarize what we have said from Oxford. Cryoglobulins are immunoglobulins that precipitate at cold temperature and redissolve on warming. Circulating cryoglobulins are causing tissue damage. They may lead to hyperviscosity or immune complex deposition, cases with complement activation, and precipitate in small vessels causing thrombosis and downstream ischemia. Cryoglobulinemia is usually strongly associated with hepatitis C virus infection. It is more common in females. What about the types? There are three types of cryoglobulinemia: type 1, type 2, and type 3. Type 1, as we said, which represent less than 20% of cases, is monoclonal immunoglobulins, usually IgM, and usually is associated with lymphoproliferative diseases, myeloma, CLL, and Waldenstrom. Type 2 and type 3 are mixed cryoglobulinemia. Type 2 is usually caused by monoclonal IgM against a polyclonal IgG, and this monoclonal IgM have a rheumatoid factor positivity. It is mostly, or in most of the cases, usually associated with HCV and autoimmune diseases like systemic lupus and Sjogren, and it has been described with some cases of lymphoma. Type 3 is mainly polyclonal IgM against a polyclonal IgG. Usually the same causes for type 2 are present in type 3 cryoglobulinemia. The clinical features are different between type 1 and the type 2 and 3. Type 1 cryoglobulins don't fix the complement, so the main manifestations are due to hyperviscosity syndrome. Might present with acrocyanosis, retinal occlusions, Raynaud's phenomena, digital ulceration, livido reticularis, purpura, arterial and venous thrombosis. But in type 2 and type 3 usually cause systemic inflammations, usually present with renal disease and rash, as we said, purpuric rash, which is painless and non-pruritic, mainly in the lower limbs. Also, there is fatigue, myalgia, neuropathy, arthralgia, GIT involvement, and lung involvement. Renal involvement usually present in around 60% of cases. Usually, renal biopsy shows MPGN pattern with intraluminal thrombi and increased number of macrophages. Main presentation is nephritic syndrome and AKI. Investigations usually shows, and which is the most important, is rheumatoid factor positivity and low C4. This is very important. When you suspect a cryo, I should ask for rheumatoid factor positive, rheumatoid factor and C4, and ask for cryoglobulins. The blood sample should be transported, as we said, at 37 degrees, ideally in a water bath, and you should rearrange it, of course, with the lab. I can take a biopsy, which will show, as we said, MPGN with intraluminal thrombi, and we should, of course, investigate for the underlying condition, especially hepatitis serology, hepatitis C virus antibody, and PCR for hepatitis C, hepatitis B surface antigen, HIV, and autoimmune diseases. We should exclude الأنا والأنتي-double strand, anti-Ro, anti-La for Sjogren, and should, of course, for full blood count and CBC film and serum and urinary protein electrophoresis to exclude the hematological malignancies and serum-free light chain assays. And if we suspect a hematological disease, we can ask for bone marrow examination. Treatment. Treatment should be directed at first for the underlying condition. As we said, in most of the cases of hepatitis C, we should treat with, nowadays, the main treatments direct antiviral drugs. In cases with stable condition or non-nephrotic range proteinuria, we should treat for hepatitis C virus, direct antiviral drugs. But in conditions with cryoglobulinemia and severe conditions, or RBGN or nephrotic range proteinuria, we should add to the direct antiviral, we should add immunosuppression. The most commonly used regimen before is steroids and cyclophosphamide with or without plasma exchange. Plasma exchange are used for hyperviscosity in severe cases, but nowadays rituximab became the first line immunosuppressive drugs. Rituximab can be used alone or with steroids, plus or minus or with or without plasma exchange. So the two most common regimens include rituximab with or without steroid, with or without plasma exchange, or the second regimen, if rituximab is not available, is steroids, pulse methylprednisolone, with cyclophosphamide, with or without plasma exchange. Thank you. Our resources include comprehensive Oxford textbook and KDIGO guidelines about hepatitis C management in case of CKD 2018. Thanks and Ramadan Kareem.